Well, I'm glad we managed to go through the venous system because of lots of catastrophes that we see post-surgery are often attributed to fate or things like that, but often the cause is venous. So the more we understand, the more we respect, the more we view veins before surgery, the less surprises we will get at the end, even in the few post-operative days. It's a true pleasure introducing Ramez Kirollos, Professor Kirollos from National Neuroscience excuse me, Institute in Singapore. Ramez and I started pretty much at the same time in Cambridge, me as a trainee, him as a consultant, and it's been a fantastic journey of friendship since. I've learned a great deal, and I have to say, even as a junior trainee, when operating on Ramez's AVMs, I thought I could do anything, and somehow it just looked all so simple. And it is because of understanding of AVMs. And I'm delighted to introduce Ramez to you, and specifically his talk on how to understand AVM. Ramez.
Thank you, Tom. Thank you, Imad and Vladimir, to allow me to join. And this continuation from the excellent talks from Igor and Victor. So this is an entirely anatomical talk. So I cannot advance.
Try space.
No.
Arrows.
Ramez, if you're on a Mac, I had this problem yesterday.
With the mouse.
You can just tap on the mouse pad.
You are on Zoom. Yeah,
Mouse works well.
Try it. Yeah. Right. So it is mainly to continue the talk, and it's to show the value of how much anatomical understanding makes your surgery technically simple and easy and make sense. Because these are complex AVMs, and as you can see, you have to have some understanding what's underlying that to undergo your surgical planning. And in fact, this is what seems to you to be a disorganized structure or lesion. You have to make some order out of it. And the more you study, the more you know, then you will see exactly what you have to do. And your technique is simple. And the fact is that we have to know that AVMs are malformations of the capillary beds. That means it is not a malformation of the arteries or the vessels or the veins feeding it or draining. So they are in a normal anatomical arrangement. Of course, there is a normal variation in normal anatomy. They may look morphologically bizarre, dilated, but still the arrangement is normal. So the more you know about the normal vascular anatomy, which you have heard in the last two lectures, the more you will understand AVMs. So the vascular arrangement, we have seen the cisternal, where you have in the arterial system, the cisternal part, the circle of Willis, but then the vessels goes to the sulci, cortical, and then we have lost knowledge of the angiographic anatomy of distal vessels. And it is very important to know it not just as a vascular surgeon, but for any intracranial surgeon, because this is how you do your tumors, your metastases, and so on. So you have to have some knowledge about them. There are other, and you have to know that all these cortical vessels, they do perforate the cortex, they do supply the subcortical structures. What we call true perforators are vessels that are perforating the brain substance without giving cortical branches. And again, it's very important to know the arrangement around the ventricle. And the fact that in the brain, as you can see here and all the other talks, that not every artery have a vein traveling with it. It's not like the femoral artery and femoral vein and so on. So sometimes they do, sometimes they don't. So the venous anatomy is very important, but what we see sometimes looks bizarre to you because they are dilated, but in fact they are all there. There are some transcerebral veins that you don't see them, and they become a problem during AVM surgery, but they are there. But the fact is, in AVM they become enlarged. So the key around that is that you have to know that all these cortical branches for AVM have a large subarachnoid segment, and then they perforate in the parenchyma itself to the AVM. That means it's imperative in your technique to have a wide arachnoidal dissection and identify these. And now it is not only to know the vessels, but you have to know how will that help you to reach the nidus. So in planning, we look at MRI scans. MRI scans are good for all these things, as you can see here. In particular, the white matter tracts. By the way, this is a photograph I took. This is the first ever human MRI machine. It is housed in the Aberdeen Royal Infirmary. It's great to see it yourself. But the MRI scan shows you some flow voids. You cannot just look at it and you know where is the feeders. You can predict them because every region has a particular blood supply, but you don't know because you cannot estimate the size accurately. All you see is some flow voids. They can be nidus, they can be perinidal. So you rely on the angiograms. And looking at angiograms is a skill on its own. This is what the radiologist will tell you, and you should know. But again, you should look at the angiogram with the surgeon eye. And what you need to know, all these vessels that they are named, the cortical vessels, you have to know where they are in relation to the brain. It's not enough to identify them on an angiogram and to be aware of the different compartments. For example, in the superior frontal gyrus, there is a blood supply both from the anterior cerebral medially and from the MCA. And then you put in your mind some structure. And this structure is a sphere. This is an nidus, and has draining veins, feeding arteries. And what you have to put in your mind, of course, there are some virtual reality models that can rotate this for you, but you have to train yourself how to see it. Because what you need to see is not only the structure, you have to put it together with the brain and white matter tracts. And then you have to look at it, how would you reach the edge of the nidus? So identifying the arterial feeders, you think you need to identify them to have control. Of course, it's useful to have control, but in fact, the most difficult vessels are the tiny ones you don't see. But the reason why you have to identify the artery, because it will take you to the margins of the nidus. And you will see from now on, the most difficult part of AVM surgery, I mean complex AVMs, is to identify the true margins of the nidus. So in summary, you rely on the MRI scan to predict where the vessels, because you know in certain areas, the frontal lobe is supplied by the MCA branches, but also you have to teach yourself how to read an angiogram and say where is the nidus without seeing an MRI scan. And we will go through them in a few examples. The other problem aspect of AVM surgery, although in the Spetzler-Martin classification, it talks about eloquence regarding the cortex, but it's the white matter tract disruption that causes your permanent deficits. There is no capacity for recovery there if you disrupt it. And how you know how to localize them? Of course, you don't have this nice white matter dissections that we all seen today in the human brain. But what we know is that deep to the U fibers, which is at the depth of the sulci, you start to have the important white matter tract. So another important technical step when you go around an AVM is to really have the adjacent sulcal dissection to the depths of the sulcus, because the depths of the sulcus will estimate to you where is the white matter tract. And luckily, a lot of the AVM major part of the nidus is subcortical. Of course, they transgress this white matter tract because they reach the ventricle, but the majority of the lesion is subcortical. So I don't have to go through all the white matter consideration, but as a vascular surgeon, that you ignore surgeons doing glioma surgery. You have to have knowledge about your white matter tract as good as any brain surgeon. And again, different deep structure, like in the cerebellum, you have the dentate nucleus and the deep nuclei. You have to know their anatomy as well. So again, to emphasize to you, this is the problem. When you open a case and you see this structure here, you don't know where the nidus, you do nothing. So you have to widely dissect the arachnoid space. You have to go through the depths of the sulci, and you try to follow what you know in the angiogram. For example, you know this artery give a branch here and then end in the AVM. You have to find it. And until you dissect and match what you already know from the angiogram, what you see, then you start your operation. And these are different examples here. Because the biggest problem I told you is what causes a lot of morbidity is that you don't identify exactly where are the margins of the nidus, which is a very difficult task because we have a perinidal zone. You can have a compact nidus like that. You can have a diffuse nidus with some perinidal changes. So you really have to identify so that you don't injure around or you leave part of the nidus that will bleed into the parenchyma. But when we look at the feeders and you concentrate on it, this is not a hemangioblastoma or a cavernoma. There is no blind ends. You don't see it angiographically, but every part of the wall has tiny feeders going into it. And you have to respect them even more than the large ones. How many there are, so your dissection around the nidus depends. If you are causing a wider dissection, of course, it does not look elegant for the operative videos, but in fact, it is a safer method to dissect because you encounter less feeding vessels. And also we have studied with Professor Michael Morgan when he was visiting us in Cambridge, we are studying the remodeling of the feeding of the perinidal vessels after resection of AVMs. So you have all these perinidal vessels, they have not remodeled yet, and they can, if you don't respect them, you can have intra or post-operative hemorrhage. What makes dissection easier are the patients who have previous hemorrhage because you have a gliotic brain similar to brainstem cavernomas. So you have a gliotic brain that increases your safety of the perinidal zone. But of course, you cannot go widely around the whole nidus, so because you will injure the structure like the white matter tract. So that's why you need to know where they are. And also you have to respect all the en passant branches. So this is, again, I know that you all know that, but this is a continuation from the excellent vascular talk by Igor. We start with the M3 branches, which is the operculum branches, and then the M4 branches of the MCA. And there is two trunks, the upper trunk of the M2 and the lower trunk of the M2. And what they give branches in sequences. So you have the lateral fronto-orbital, you have the prefrontal, they are multiple and they can have branches. There is some variation in them. You have a pre-Rolandic branch, central or a Rolandic branch, and the anterior parietal. But you have to know where they are. So on the brain, because it's not enough that you know their names without knowing where they are on the brain. So this is, I put you here in where is the location adjacent to which sulcus. While the lower trunk gives the first branch, which will be the posterior parietal going to the superior parietal lobule, while the angular branch giving the lower inferior parietal lobule. Then the temporal lobe will get the posterior temporal, anterior temporal, and near the lateral part, the temporopolar branch. And you have to know where they are located as shown on this table. The anterior cerebral is easier. We already have seen them. So from the proximal A2s, you get a fronto-orbital branch going to the orbital surface of the frontal lobe, while the frontopolar going to the frontal pole, and then you have the supracallosal segments, A3, A4, and A5, while the callosomarginal is adjacent to the singular gyrus and supply the superior frontal lobe That's why this is a saddle area that gets blood supply from both MCA and ACA. Now, this is important to recognize the distal branches of the posterior cerebral artery, which have this configuration. You have a first segment in the interpeduncular cistern, and then the P2 in the cisterna ambiens around here. And the P2 gives the important cortical branches. It gives the lateral posterior choroidal artery, which really goes to the choroid plexus, but gives some supply to the parahippocampal structures, while you get two small branches. You don't normally see them large, but they are very important in the AVM, which are on the tentorial surface of the temporal lobe, the anterior and posterior temporal artery. And then just at the junction between the ambiens and the quadrigeminal segments, you just get this splenial artery, or Igor called it the posterior callosal artery, which is important because we operate on few corpus callosum AVMs, and that becomes an important feeding artery. And then it terminates in the two terminal branches, which is in the parieto-occipital and the calcarine fissure. When you look at the angiogram, this wasting here is the area where the tentorial hiatus lies. So all these segments are supratentorial and on the medial occipital lobe. So you have to know where they are. So we'll go to frontal lobe AVMs. You can read the table yourself, but these are the branches that comes and supply the surfaces of the frontal lobe. You have a lateral surface, a medial surface, and an orbital surface. And these are the arteries that we go through them and how to identify them on an angiogram. So we'll take examples. So if you look at this angiogram, now the problem with AVMs, that the arteries are shunting the blood, so you don't see good filling of the other branches. But what we see here, that this is probably, so what you have to identify is really the opercular segment, which is the M3. And it has a distinct appearance. They look like semicirculars or loops. So you know that the operculum is here because of the appearance of these vessels. And then you have this segment, which is an M4 branch. This is probably going to be one of the pre-Rolandic branches. So this AVM is more or less in the middle frontal gyrus and draining to the veins. And then you can follow the veins, and you know, and the artery will take you to the margins of the AVM. For example, there is another extra draining vein which will tell you where is the posterior margin of the AVM. And if you go deep, if it is deep to the U fibers, it will involve the SLF. And exactly here, as you can see, bang correctly in the middle frontal gyrus in the premotor area. And deeper you get, deep to the U fibers, the SLF. Now this example, again, to show you how. So this is a more posterior one, so this is a Rolandic part. And you can tell because on the AP, the central artery is the most lateral in the AP projection. However, this is opercular segments. I told you it looks like semicircles, and this is straight on the pre-central gyrus, which is usually the face area, which is luckily bilaterally represented. And then you can again get the poles. And then if you go deep, now this is an exception because the corona radiata is not deep to the U fibers, it's a projection fiber. So if you go anywhere deep, you will damage the motor cortex. So that's why deep sulcal dissection is not useful here. Again, this is an example how a true operculum AVMs in the language speech area. This is a motor area of the speech, and it's really in the inferior and frontal gyrus, and going up with all these veins will take you to the margins of the poles of the vessels, and you would know that it's taking blood supplies from the prefrontal gyrus, and deeper to it, you will affect the arcuate fasciculus and the language area. And here are the opercular branches. So it is located in here in the frontal operculum. So deep, as you can see, deep to the sulci, the U fibers, you start to have the arcuate fasciculus, which is the deep part of the SLF, and deeper to it. The frontal pole has a blood supply laterally from the MCA. So this AVM is supplied laterally from the MCA, lateral frontal orbital branch, while this one is medial and it's supplied from the frontopolar. So this is the A1 and the A2, giving the A2 proximally, giving the lateral orbit. This is, sorry, the frontal orbital branch, while the M2 giving the lateral orbital branch. And the way to do it, if you look at the ICA silhouette, which is here, this, of course, this is different side, but if it is lateral to the silhouette, then it's supplied by the MCA. If it is medial, it's supplied by the ACA. So looking at the angiogram without an MRI scan at all, you can tell where it is. The medial ones, as you can see, there is a pattern now, so you know that this AVM will be adjacent to your SMA area and the cingulate gyrus, and deep to it, there will be the white matter tract of the cingulum. So you'd expect this patient to have a transient mutism and hemiparesis if they have an SMA syndrome. So this was the frontal lobe. The temporal lobe is more complex because it has a lateral surface and tentorial surface supplied by both the MCA branches. And again, they are coming from the lower trunk of the M2 and starts from the pole will have the temporopolar branch and then the anterior posterior temporal. This is the lateral surface, while the tentorial surface is getting blood supply from the P2 segment, giving the anterior and posterior temporal branches, and again, some of the other branches to the opercular, to the choroidal fissure. So this AVM, you can see is coming from the lower trunk of the M2, straight after the operculum. So this, I would expect, coming out here, will be located, looking just on the angiogram without an MRI scan, will be locating as the superior posterior part of the temporal gyrus, which will be the language area or the speech, receptive speech area. And you can tell, again, it is draining towards the transverse sinus to one of the Sylvian system. And again, the white matter tract deep to it will, of course, involve the distal part of the vertical part of the arcuate fasciculus, and deeper to it, you have the optic radiation. This one is another one, and just looking at the AP, it's getting blood supply from the M2 lower trunk. So this is an anterior lateral temporal AVM. But look at the angiogram and the wealth of information. It is draining to the vein of Rosenthal. That means this AVM is extending to the tentorial surface or inferior surface of the temporal lobe. Otherwise, it won't drain deeply. And again, if you look at the AP silhouette, if it was in the uncus, it will be extending medial to the carotid, but it's all lateral. So we know it is lateral basal anterior frontal AVM by just looking at the angiogram. I'm not telling you you don't do an MRI scan, but there is a wealth of information by studying the vessels, and you know that this, to get proximal control of these arteries or to find them, you will open the Sylvian fissure.
Ramez, I hate to sound like an anesthetist, but you have 2 more minutes.
Oh my God. Okay. So this is another one in the tentorium surface, and you can see a large temporal branch from the P2. And again, similar one. So I'll go quickly through them. This one is in the parahippocampal gyrus, and you can tell going to the choroidal fissure because there is some supply from the anterior choroidal artery, and it's draining to the vein of Rosenthal. And again, here is the choroidal fissure, and you can see the parahippocampal gyrus and the vein going to the vein of Rosenthal. The parietal lobe is similarly, so I will just show you the slides. And again, this is an inferior parietal lobule. This is again the paracentral lobule on the medial side. And the occipital AVMs, of course, this is in the primary visual cortex. I will do quickly, Tom, just the cerebellum very fast, very fast. So you
no
have
problem. No need to be too fast. It's
okay.
an important part. I will shorten my talk later.
No. So you have the three surfaces of the cerebellum, because AVMs, you know, my first 176, quarter of them were cerebellar AVMs. So there are a lot of AVMs there, and you have to know the anatomy of the loops of the, because they get some flow aneurysm. So this is the arrangement. So the suboccipital surface is mainly supplied by the pica, but you have to appreciate that the main blood supply of the cerebellum is the SCA, to the extent that a lot of the lateral suboccipital surface is coming from the SCA, while the SCA supplies the whole tentorial surface, while the petrosal surface adjacent to the flocculus is applied by the postmeatal part of the ICA. So these are cortical branches. What is important that the vermis itself gets a large, this is from Pablo, I borrowed this from him. The vermian vein of the pica goes up to the superior part of the vermis. So an AVM in the top of the vermis will be supplied by the pica and the SCA as well, while a high AVM here may not be supplied by the pica at all. Now the venous groups, I divided them into regions. The midline regions, superficially, the veins is draining adjacent to the straight sinus, not necessarily directly, but through the tentorium, while more deeper, they go to the galenic system. The paramedian part, so this, you can see the veins are not following the arteries at all. They are all draining to the tentorial surface into the transverse or straight sinus, while more laterally, you get the petrosal drainage. And very important because they can be connected to the middle pontine vein, and you have to be careful to occlude it, not at its end, but as near to the nidus as possible. These are examples of AVMs, and you can see the petrosal one in the anterior one, deep AVMs and insula, we cannot go through them. The thalamus gets anterior supply from the thalamo perforators and the genicular perforators on the lateral side. And what to make surgery easy, we advocate that we use the white matter, the liquefying hematoma that have dissected the white matter tract. So if you have a hematoma that in the subacute stage, use it to cause the dissection for you. And I have used it in many cases out of my AVM surgery. So the takeaway message that you have to plan your surgery. There is nothing called intracranial laparotomy. You have to know it before you are operating. The cortical vascular anatomy I showed you is not just important for vascular surgeons. It's important to know for everyone. And if you know the normal anatomical patterns, you will have a pattern recognition in your mind for the different lesion, and always use your draining veins, which you keep till the end, as a guiding pathway to the AVM nidus, while use the feeders to tract the outline of its margins. So this is very important in your surgery. And use the arteries because they are in a normal anatomical location, so you know where to find them, and then follow them to the nidus. And they are bizarre in shape because they are wide and it is easy to find them. So the last slide, don't subspecialize your knowledge, but subspecialize your practice, so you know brain anatomy the same as vascular anatomy, whether you are a vascular surgeon or brain surgeon. And just for completion, this, in fact, was the orbital AVMs because it's draining into the superior orbital vein. Thank you very much, Tom, for allowing me to overrun.
Thank you, Ramez. It was a great pleasure, and I'm sure the pleasure was not only mine, but of the entire audience. We don't have a great deal of time for questions now, so I think we'll skip it. And perhaps while you are ending sharing, which you have, the next speaker, Professor Benesh, could get his sharing up and running, which is already happening, I can see. It is a true honor and pleasure introducing Professor Benesh. Professor Benesh is former chairman of the Anatomical Committee and is joining us from the arguably most beautiful city in the world, Prague. And So we have learned about the brain, we've learned about arteries, veins, and arteriovenous malformations, or how to read them on scan, how to think about them. Now we're going to hear about tricks and tips how to resect AVM.